Thank you, Diedrich, for that very nice introduction, and good afternoon, good evening, everyone. Those drinks sounded very, very good, but I think after this session, we will all get some. So I'm very, very pleased to be here with you today and talk to you about what trends we see in WHO taking place in primary healthcare during the pandemic. And I will talk more about the trends we're seeing in the European region. I sometimes like saying, what if a bird flew over Europe over the past year and a half? What would that bird have seen in primary healthcare? And we would like to really capture that and put that in the center of our work program. Let me share some slides with you to give you some visuals of my presentation. So we think that over the past year and a half, there has been unprecedented transformation at the primary healthcare level. And if we manage to capture some of them and learn lessons, we can really realize the potential of primary healthcare to a great extent. Now, what this transformation has been at the primary healthcare level is to reply or respond to the pandemic context with a very rapid adoption of what we labeled as the dual track approach. And that is to contribute to the pandemic response on the one hand, but also maintain the operation of essential health services. And we have written and spoken about this a lot. This is not the topic I would like to talk about today. This is just the context. But if you really think about it, what this means is that the work of primary healthcare magnified and multiplied in a very short period of time when the resources have remained relatively stable or increased somewhat. And here I'm not talking about financial resources in particular. I'm talking about resources like human resources, expertise, know-how, and so on. So when such adaptation and transformation is taking place, and we have seen that everywhere. We have seen this adaptation and transformation at national levels to rapidly bring on board policies that enable this dual track approach, at the regional and community level to really work with the population and deliver a range of services, and at the facility level. And we do believe that we have a duty in this context to document and analyze and learn lessons. What we have started doing is we have been working with countries, with country authors to document some transformational approaches to primary healthcare during the pandemic. And we have launched a series of country vignettes. And in the left side of the slide, you'll find a link where you can take a look at them. Within a couple of weeks, we will have about 15 of these country vignettes online. We currently have 9 of them. We believe it's very important to learn from the front line, because very often change in these rapidly changing times happens there, and it's very important to capture it and document it. Therefore, we're very proud of this series of country vignettes that may not be the most academically produced series. They may not have the evidence, but they really try to capture the spirit of change, what actually happened, what facilitated change, what were the challenges, and what are the sustainability prospects for some of these. In my presentation, I will narrate quite a few of these country vignettes to create some appetite for you to click the link and go there. Now, to complement these country vignettes, we have done a quite serious effort to analyze cross-country trends with our partners at the European Observatory. As you know, the European Observatory launched a health policy response monitor at the start of the pandemic, where country-based teams were documenting a wide range of responses to the pandemic in all areas of health systems. In the earlier part of this year, we have teased out from this health system response monitor the primary healthcare relevant responses. And you can see in this article that recently was published in Health Policy, we have tried to capture the main trends and think about what that implies for the future. And there are 4 main trends that we're talking about, and these are the 4 main trends I will also highlight in my presentation. First, there has been a strengthening and acceleration of multidisciplinary collaborations. Second, there has been intensification to identify and reach the vulnerable more rapidly. Third, there are acceleration of implementation of digital solutions in the context of a multiple platform of service delivery. And fourth, a lot of the change happens in the front line at facility level, and it's very important to have systems in place where we can document them over time and analyze them and learn from them. So as I highlighted, we are seeing a shift towards multidisciplinary teams to increase the resolutive capacity of primary healthcare. And this has been a long-standing trend in Europe, where countries have moved already to a great extent to multidisciplinary teams. But for us in WHO, Europe is a very large territory. It includes not just the countries of the European Union, but as you move to the east, all the countries of the former Soviet Union, as you move to South, Turkey and Israel as well. It's a total of 53 countries, and quite a few continue to operate with a more traditional model of family physicians and nurses working in tandem. What we are seeing during the pandemic, first, that countries that already have multidisciplinary teams in place, for example, Spain, and you can read in our vignette, interesting task shifting has happened during the pandemic. First of all, the multidisciplinary team's size may have increased, and additional health workers were added to primary healthcare teams to cope with the demands. But there has been task shifting to nurses and to administrative staff. For example, nurses have been managing some of the COVID pandemic-related trends, participating in the triage, the management of mild cases, visiting nursing homes, and working side by side social workers. And administrative staff became much more proactive in demand management and priority setting of the cases and identifying which cases need to be seen face to face, which cases can be consulted on the phone, or which cases need a mobile team visit. So this task shifting is also something that has been in the books. We have been wanting to achieve this. We saw this as the future, and necessity dictated so that during the pandemic in many countries, this has happened. And of course, this brings up a lot of issues for the future, because the action had to happen fast. Was there in place proper guidelines, proper guidance, proper training for all those health workers that all of a sudden had to assume greater responsibilities? And when we talk to health workers in different contexts, we see that two sides of this coin. On the one hand, we see that this increased responsibilities and improved teamwork in many cases is a great motivation. On the other hand, being given bigger responsibilities for overstretched health workforce without the tools to respond is one of the main sources of psychosocial stress for health workers. And I will get back to this later. So one of the challenges in this, as we move forward, is not just to learn from the facility-based innovation, but to systematize that learning and provide not emergency solutions, but more systematic solutions in the future, as we had done with proper policies, guidelines, and training. Now, the countries that didn't have multidisciplinary teams in place, there has been a great recognition of the importance of this, and in particular to the extent that the role of mental health workers and social workers, together with primary healthcare, family physicians and nurses, emerged. And in many cases, it became clear that it is primary healthcare that's closest to the people. And they're the ones that can deliver services, while a wide range of public and private services in other spheres were shutting down or struggling to maintain response. So primary healthcare was very well positioned to take a role not only in delivering health services or physical health services, but broaden that scope to focus on mental health and social work and support households in a wide range of needs. Kazakhstan is a very good example of this. Kazakhstan was putting in place multidisciplinary teams before the pandemic, and during the pandemic, they fully understood the importance of this and accelerated the work of these teams. They were in a very good positions to do this because there had been guidelines developed for the mental health workers and the social workers during the pandemic. And what was also very interesting is that they were able to mobilize this primary healthcare teamwork and dispatch them through mobile teams to the patient's homes. And in instances, it could have been a COVID-related call that triggered a mobile team visit to a patient's facility. But as time went on, it became clear that the real need was continued and long-term mental health support or social worker to bring along the medicines or provide food or mental health support to isolated people. So this is a very important trend, and we do believe that as we look into the future, those countries that continue to operate with the family doctor-nurse duo or smaller monoprofile teams will also seek to expand this, at least to the extent as mental health and social work is involved. And here we from WHO side, we will try to provide some guidance on how to compose multidisciplinary teams. The key conclusion is there isn't one size fits all, not even within one country, right? Because it's most important that these multidisciplinary teams respond to the context, to the health needs of the population in that particular community, that particular catchment area. So while there needs to be some general guidelines, in some areas we may need to have more nurses. In areas where there's a lot of sort of urban or internal or external migrants and a younger population, we will be probably needing a very different composition of a multidisciplinary team than a rural area from where the younger population has migrated away, a lot of elderly, a lot of multimorbidity with the lead of chronic conditions, etc. So this is a very interesting area where we will all need to think and put our heads together of what are some general lessons learned that we can provide. The second area that we see as a major trend is, of course, during the pandemic, there was a huge imperative to act on our principles of solidarity and identify and reach those who are vulnerable. And here, when I say vulnerable, we may mean a range of vulnerabilities. One is when we think of health, of course, we have to think of the high-risk, complex patients that we are traditionally quite good at identifying at primary healthcare level. But during the pandemic, we have to expand this definition of vulnerability with issues related to mental health and issues related to social vulnerability. And I believe that the countries have done this differently. Some countries have very, very strong digital tools, risk stratification databases to identify those who are highly vulnerable from a health perspective. And those countries that are most advanced, like United Kingdom, like Spain, they already have abilities to integrate mental health and social vulnerability in the definition of this. I believe we will see a lot more of this in the future. But as we go towards the east in our region, the ability to identify who are the vulnerable in the catchment area of primary healthcare becomes weaker and weaker. They may know separately who are the high-risk diabetics, who are the high-risk cardiovascular patients, who are the high-risk pregnancies. But this comprehensive ability to tease out who the vulnerable are at the catchment area is very, very challenging. And this is a huge opportunity in the post-pandemic area to leapfrog and accelerate, because the mechanisms to do this are quite well known. And we will seek to provide support to this area. When we were looking into the country examples, however, we have understood a number of things. First of all, I was fascinated by our country vignette from the United Kingdom, which has a very, very strong risk stratification ability in identifying those who are high risk. And yet, to go broader than risk stratification and identification of the vulnerable from a health perspective, what we saw is the emergence of partnerships of primary healthcare providers working together with a range of non-governmental organizations to have a much more comprehensive ability to identify those who are vulnerable. And they jointly delivered not just health services, not just mental health services, but as you can see on this slide, food parcels to residents, welfare and befriending calls to take care of those who were isolated, taking health services and medicines to those who were shielding, and so on and so forth. In France, we were seeing similar trends. In this vignette, we document from one particular region of France, we saw a very strong collaboration between primary healthcare and the local government to be able to also bring in the social dimensions of vulnerability and deliver services comprehensively. I do believe that in this area we can move forward. Those countries really, when the pandemic a little bit gives us the chance, countries do need to analyze their own systems of to what extent we have good system in place to identify the vulnerable in our primary healthcare catchment area. Where are the strengths, where are the weaknesses, how comprehensive are we, how far we have already moved away from the disease-specific definition of vulnerabilities or just considering physical health. To what extent can we also incorporate mental health and social conditions in our definition? And how rapidly can we reach those people who our systems are identifying as vulnerable? I believe this analysis is very, very useful for all countries. And then having learned from the pandemic of what it takes, stepping up the information solutions, information systems, but also really investing in partnerships, public-private partnerships to deliver a wider range of services is a very promising approach to strengthen primary healthcare and strengthen equitable delivery of primary healthcare and health equity. The third trend we see is the most obvious one, right? So if this bird that I mentioned at the beginning was flying over Europe, what this bird would see is that all of a sudden we have multiple platforms of delivering primary healthcare services face-to-face in the facility, but increasingly face-to-face in people's homes through mobile teams and mobile services, and a huge increase in remote delivery of services through passive provision of information through internet sites, through phone calls and video conferences, and so on and so forth. We will never return to the past of the full face-to-face delivery of services in facilities. And the key question becomes how we cleverly combine these different services. And we have to understand the comparative advantage and the appropriateness of the different services vis-a-vis different types of people and vis-a-vis different types of health conditions or consultations. This is a very interesting question in itself. For example, when we're delivering services remotely, let's say a mental health consultation to a teenager, how do we know who else is in the room of that teenager? So confidentiality issues become an issue. Of course, from the population perspective, some people are very apt using digital tools and some people are much less so. So we have to really think about and systematize what type of services to be delivered to whom on what basis. And there are some important challenges. The first one is change management, and managerial leadership becomes very critical to operate in this new world where we have to not just to triage patients to different primary healthcare teams or doctors or how rapidly they will be seen, but through what type of platform they will be receiving the services. The digital health literacy of the users is a very important issue, as well as the digital competency of the healthcare providers. And in all of these areas, there is quite a big range of a desire to use these services and move to different sets of platforms. So when I made that strong statement, we will never return to the past, I'd like to make a little illustration from Lithuania, which I find very interesting. You can see the number of direct face-to-face in-facility consultations in blue, and in yellow, the remote consultations. And you can see how the peaks of the pandemic ebbed and flowed over the past year and a half. We started out with a very, very tiny amount of remote consultations, and that changed rapidly in the first 3 months of the pandemic. And there was a very dramatic increase in remote consultations as the first pandemic peak was approaching. This was facilitated through, like in many, many countries, through emergency legislation, very rapidly put together to enable various forms of delivering services and protecting the health workers. But there had to be a lot of facility innovation and managerial leadership in this to put this in place to make sure that the health workers and the population felt confident in this new approach. And then what I find really interesting, as the pandemic peak subsided, you can see that the direct consultations continued to increase, which is a very good thing. Probably some of the pent-up demand of essential health services was caught up, but the remote consultations remained a very significant part of the consultation mix. And our expectation is this is going to continue. And there are many areas where these have actually created some efficiency gains, like some of the routine consultations, some of the repeated consultations, for example, renewal of prescriptions or provision of sick leave, both for the health workers, but also on the patient side. The lesson that I personally learned from the Lithuania case, I learned two lessons from this case. The first one was what I already referenced, that often these new digital platforms were enabled by emergency legislation, that going forward, we have to systematize what type of platform will be used, how. We will need to have probably, for some conditions, new guidelines. A consultation online may be different from a consultation that takes place face-to-face. Consultations online give us the opportunity to, let's say, for example, bring in a specialist, for example, in some complex cases that is located in a different physical area. So there are a lot of opportunities here. But all this will require a more systematic approach than what we have done during the pandemic. And here, the imperative is to really learn from managerial leadership that made it happen, made it work during, and ask our health facility managers, what would you need from us at the policy level to make this work more systematic and more supportive? And I think this is a very interesting lesson because very often we do things the other way around. First, we figure out the policy, then we train people, and then we ask them to implement it. But here, the practice was very much ahead of us. And I looked at carefully the subtitle of the conference this year, Policy, Practice, Imagination. And I like the last word in particular, because I think we had to act so fast that the practice had to be ahead of the policy and the context. And facility managers, facility level leaders, community leaders had to use their imagination how to respond to some of those challenges. And I think that's really, really beautiful to document it and systematize it in the future. And that takes me to the fourth point. Please don't worry about the details of this graph, but really we need to systematize what we have learned at the facility level, because it's truly impressive how demand has increased, right? What we try to show on this graph is that in pandemic peaks, and you see this in dark blue, there is a huge surge in need at the primary healthcare level to participate in the testing and the contact tracing and the management of the mild and moderate cases, a huge, very rapid increase in workload. And that probably leads to a temporary crowd out of essential health services, but those don't go away, the vaccinations, the chronic patients, the chronic cases. And when the pandemic peak subsides, there will be a further increase in that. And all these pandemic contexts, together with the economic and social problems, we know lead to an increased set of health problems, including mental health problems, and lead to demand for more health services at the primary healthcare level. So what we really predicted fairly early on in the pandemic, that at primary healthcare level, we're going to encounter a very dramatic increase and a sustained increase for health services over time. And to what extent can our resources, our health workers, their knowledge, training, etc., keep pace with that is a very big challenge. And the only way to adopt is through innovation and adjustment and agility and finding clever ways to do more with marginally expanded resources. So that very much surprised me in this line is from the Russian Federation, where prior to the pandemic, they focused very much on improving productivity at facility level. They have very large multidisciplinary polyclinics in Russia, and they have done some analysis of documenting and identifying inefficiencies in these health facilities that led to very long waiting time, long presence of the patient at the health facility, many steps that they had to go through. And they documented and analyzed these, and they applied lean management techniques prior to the pandemic, starting with a phased approach of early adopters, learning from those experiences and rolling it out to others. And what this vignette is about is how their increase in efficiency and productivity at primary healthcare level and the ability to be better at management and identifying their own inefficiencies and productivity issues. This is what helped them during the pandemic to respond and put in place the dual track so well and so rapidly. And this definitely brings us to the issue that when we talk about management of large multidisciplinary primary healthcare teams that are often or increasingly networked, that's a very significant management challenge. It's not the same level of management as managing dual practice of a family doctor and a nurse. And for thinking about the future, it's quite important for countries to invest in management for primary healthcare in particular. And we in WHO, we would be very happy to serve as a platform to connect institutions that are interested in offering specific training in the management of primary healthcare, specifically to make it more efficient and more people-centered. Now, to implement these in the future, and you heard my main themes: learn, systematize, continue, scale them up. The most significant investment we need to make all these wonderful developments sustainable is to invest in our workforce. We really need to think a little bit ahead and predict demand for primary healthcare, horizon scanning, so to say, and think about what kind of health workforce numbers and composition can meet that demand. We need to think about our education and training. And recently, some of you know our series of talk shows, Let's Talk Primary Healthcare. In our season finale in June, we invited 4 young health professionals who work at the primary healthcare level from 4 different countries: a family doctor, a nurse, a social worker, and a community pharmacist. And it was so interesting to listen to them. They were extremely inspired to work in this multidisciplinary environment, seeing the patient holistically, not just the disease, not just the condition. But they said when we came out of our training, we were extremely poorly equipped for this, because our training focused on the disease, our training focused on the diagnosis, it focused on biochemistry, etc. And our training took place in hospital setting, not in the real setting of primary healthcare, where part of the job is to understand a range of organizations that work together to provide this holistic service. So I think there is still scope to think about our education and our training, to what extent it's fitting to this new vision of multidisciplinary and networked approach. Pay and working conditions are a big issue in many countries, and only with the increased and enhanced resources to primary healthcare, we can adjust that. But what the pandemic has brought a spotlight to is really the last item, is the health and well-being of health workers, or the support of the health and well-being of health workers. A few countries in our region, like Ireland, like Israel, have very strong programs in place, occupational health programs, to provide systematically support to the health and well-being of health workers. For example, prior to the pandemic, they had surveys about mental health and stress levels, etc. And during the pandemic, they could build on these and step up their already pre-existing programs. But in most of the countries, these didn't exist and continue not to exist. And an important learning from the pandemic is that this is something we collectively need to invest in, to be able to take the temperature of the health workforce and to provide support through a wide range of programs. So let me end my presentation to talk about how we would like to provide support. All the themes I have mentioned will be themes that feature very strongly in our work program. How we provide support. We provide support through direct country support or through regional, what we call regional and global products. In both of these cases, we really seek to support task forces on strengthening primary healthcare policy that we hope become increasingly multidisciplinary themselves. In our direct country support, we seek to engage with them, and through our regional and global products, we seek to connect them into a regional network that will become thriving. And already there are lots of examples and partners who are doing this, and provide a platform for cross-country learning and engagement. In our direct country support, we work often on policy advocacy and building political commitment to primary healthcare. We work on country assessments and performance diagnostics, strategy and policy development, hosting policy dialogue platforms or executive consultations, and increasingly to provide implementation support. In our regional and global products, we are launching a policy paper series, and as you have seen, we have launched a country vignette series. Our country vignette series are going to continue post-pandemic. We're going to have mini-series within them. This first set you saw is about transformation during the pandemic. We will have further mini-series on the next one coming online will be about bridging access gaps in remote and rural areas. And in other areas as well. We have launched a regular dialogue platform, Let's Talk Primary Healthcare, and we are going to continue this. And we will complement these 2-hour dialogue platform with more in-depth conversations or mini conferences about key policy issues. We will be launching a course early next year with our headquarters and other WHO regions on primary healthcare policy. This will be a modular course with an online component that will be global for a global audience, followed by an annual face-to-face week-long learning course that we will be hosting. We also have a primary healthcare performance monitoring course and coaching with our collaborating center at Amsterdam University. And we will be bringing online some simulation exercises and learning opportunities on the role of primary healthcare during the pandemic. We would like to launch some demonstration sites in Europe, showcasing in practice well-functioning primary healthcare systems and give an opportunity to those who are interested visiting them to engage with those working in this demonstration site at facility level, community level, local government, national government, of how they have overcome implementation barriers. And on this, I thank you for your attention, and the most interesting part of this hour will really be your questions and reflections, and I look forward to the discussion. Thank you very much.